Welcome back to Mostly True Psychiatry. Today we're going to be evaluating delusions and hallucinations. We'll be talking about some questions for evaluating auditory hallucinations, the delusions that really are going to matter, or at least the kind of core concept when you're evaluating persecutory delusions, like delusions that are scary, and then how to evaluate for malingering of hallucinations or delusions. So let's go to our questions for evaluating delusions and hallucinations. So for auditory hallucinations, these are the kinds of questions you should be asking. You don't need to sound like a robot. If you just want it to be very crisp and mechanical and impartial, you can ask them exactly like this if you wanted. So it's like, what are the voices telling you? Do you have any beliefs related to what you're hearing? Do you know who the voice is? Do you believe the voice is real? Are the voices wanting to harm you? Do you do anything to make the voices go away? Do you feel the voices can control you or others? Do you believe the voice is powerful? How do the voices make you feel? Have you ever done what the voices told you for command auditory hallucinations? Fun fact, 50% of patients with schizophrenia, no relationship to anything. But it's a big deal for some reason. So persecutory delusions, I made a special section for it because if a person's being tortured, mentally, like they think horrible things are happening, they're really scared, you want to know, right? You actually care about your patient, you're trying to help them. A patient I've had before, I think it was like tuberous sclerosis, it was just purely organic brain, dysfunction, but believed that people wanted to eat him. Like he could hear people talking, like his neighbors through his wall, and when he's at stores, hear people like thinking they were watching him and stalking him, and they literally wanted to kill and eat him. So persecutory delusions can be really bad. So kind of the framework of questions or things you might want to ask are like, who or what do you believe wants to harm you? How is that person attempting to harm you? How certain are you that this is happening? Is there anything that can convince you this isn't true? How does your belief make you feel? Have you thought about taking any actions because of these beliefs? So again, command. How much time do you spend thinking about these ideas daily? In what way have these beliefs impacted your life? And kind of the follow-up question or alternate. Do you change what you do because of concerns of being harmed? So a piece that matters to that is malingering, right? Are people faking it? Are they lying? So first you kind of need a motive, right? You need a reason to be wanting to malinger. It's either to avoid negative consequences, which is like, being arrested because they're currently going through a criminal prosecution, or, avoiding military conscription, something like that. Trying to avoid some kind of negative consequences, or to get a benefit because that gets them drugs that they want, free room and board because now they're disabled, financial compensation, disability, those things, workers' comp. So you should be aware of why it might be happening. So the interview style, if you have suspected malingering, it just depends on how much effort you want to put into it. This is really, to some degree, this is forensic psychiatrist works, not for the generalist, but you can look for red flags. So obviously, maintain objectivity. Don't look super annoyed like you're full of crud as soon as somebody says something that just doesn't make sense. You should do your open-ended questions. Let the patient respond in their own words. Don't give them the symptoms. Carefully phrase the type of symptoms you're trying to ask them, like about anxiety, but not tell them the anxiety symptoms. If you got enough time, go for collateral. You can make the interview long because they start getting tired, and if they're trying to do like psychosis, you'll wear them out maybe, and it just doesn't. They start off all confused and stuff, and by the end they're not doing it. So they're obviously faking those internal symptoms. What else? So then you start just kind of evaluating, for consistency of what's being said. So it's either like the internal or kind of external consistency or the ideas. So internal consistencies, like, are they just saying the same things and it matches up during the conversation, or are they contradicting themselves within the same, interview type thing? External inconsistencies could be things ranging from the previous interview they did and what they're saying now with you versus that other psychiatrist or whatever isn't the same. Like, especially if you ask them questions about the past and they're messing up their facts when they're trying to remember backwards. Also, from what they're telling you, like if I told you right now, I'm so anxious, I think I'm about to die, I can't breathe, I feel awful, my chest is so tight. But you're looking at me and you're like, you don't look anxious at all. So your mental status exam. So if they don't match up, they don't look psychotic and they're telling you they're psychotic, and no negative symptoms or anything, and use that as possible evidence of malingering. One I particularly like, I love this idea, is you just intentionally feed them crap that's never gonna, basically never true. Like, do you see the words written in the air when you hear the voices, or all the objects you see in black and white? Things that people don't say when they're psychotic. The kind of specific signs you're looking for is like the person gets real guarded or hesitant, like they don't want to answer questions, assuming it's not paranoia and they're floridly psychotic and it's obviously they're schizophrenic. If you ask a question and they repeat it back to you because they're trying to process it, so they give you a fake answer, or if they just keep saying I don't know, right? They won't answer any of your questions because they don't know what they're supposed to say. If you ask those 50 questions, for Persecutory setup, they start trying to guard what they say because they're going to say the wrong thing over time. If a person is hostile or intimidating, I would just immediately go malingering and just until proven otherwise. I mean, that's pretty cruddy if a patient's trying to just force their way right through it. Won't refuse to participate. Again, always watch for just if they're really scared and they think there's Persecutory set up, then those are things that could happen realistically for a psychotic patient. Overly dramatic. Basically, if it looks like they're acting, right? That's what you mean. And that's a kind of unusual statements that don't make any sense. Like they're believing that cars are part of an organized religion. It's like without more information of that, if that's where it ends at, just cars like by Ford are part of the Catholic religion. Like that's ridiculous. So kind of uncommon delusions. You're looking for the abrupt start and stop. That doesn't sound like psychosis at that point. Maybe they had a brain injury, maybe they're confused, maybe something else. But if what they're doing doesn't match their delusion, red flag. If it's a really bizarre delusion, but they're not disorganized, because you can have really weird delusions that make no sense, but the patient's completely disorganized. But if they got all their stuff together and the delusion's really, really weird, probably malingering. I don't like this one. This is one that gets used sometimes by Resnick and them. So patient is eager to discuss the delusion. I met plenty of people with schizophrenia who they're fine talking about it. They're talking about their blueprints or something, right? Like they talk about blueprints. Let me tell you about my blueprints. Let me share them with you. It's like just because they like you. I mean, they'll do it, or they're just into their delusion. It's fine. For hallucinations, the things are, it shouldn't be continuous. If they shouldn't be going 24/7. If the voices are always vague and inaudible without medication, If they're using a weird way of talking that not like common speech, it's pretty weird. It's probably not true. They have hallucinations and then they have delusions and they're fully separate. Or most people, if they have hallucinations long enough, they start to build delusions around them. It's basically, at least my pet theory about delusions are just a result of hallucinations. The content of the delusion is a result of hallucinations, is what I mean. And just ask them weird questions, like, are they in black and white? That wouldn't make any sense with schizophrenia. And if they just have visual hallucinations, nothing else, or just auditory hallucinations and nothing else, if they're not super depressed, manic, or obvious, or schizophrenic, then those type of just a hallucination isn't reasonable. It's probably drugs or just lying. All right, I think that'll get you started on that kind of stuff. I hope you found that helpful. Malingering, something you will have to deal with. Be super sketchy about all these, patients trying to get disability paperwork or these kind of things for mental illness. Make sure you're doing the right thing. All right.